It is about iron deficiency. So I'm going to talk about several facts here. So iron deficiency can manifest as anemia, and it can again manifest as without anemia. So first I'm going to talk about definition and prevalence of anemia and iron homeostasis, distribution of body iron, and dietary requirements and causes of iron deficiency, clinical features, investigations, and iron deficiency, how to assess iron deficiency in chronic inflammatory conditions, and how to establish the cause for iron deficiency and management. And finally, I would like to talk about iron deficiency without anemia as well, because it is very important topic. So according to WHO definitions, anemia is defined as in males HB less than 13, and in females who are not pregnant when hemoglobin is less than 12, and in pregnant ladies when it is less than 11. So again, it is categorized as mild, moderate, and severe anemia. So in male patients, if it is between 11 and 13, it is taken as mild, and 8 to 11 as moderate, and if it is less than 8 as severe anemia. And in non-pregnant women, if it is 10 to 11 as mild, and 8 to 10 as moderate, and if it is less than 8 as severe anemia. In pregnant patients, severe anemia is taken as hemoglobin less than 7, and moderate as 7 to 10, and 10 to 11 as mild anemia. So prevalence of anemia is assessed in 2011 WHO consensus, and they have found in Southeast Asia about 41.5% of non-pregnant women and 48.7% of pregnant women, and all women in reproductive age of 41.9 as anemic. So out of these patients, majority are due to iron deficiency. So when you talk about the regulation of iron balance, iron is absorbed as ferrous ions. So ferric ions are converted to ferrous ion with iron reductase, and it is absorbed into intestinal cells, mainly in the proximal duodenum, and then taken into the plasma, which is regulated by ferroproteins. So ferroprotein level is regulated by hepcidin, which is the main iron regulator. So our body iron stores are mainly in liver and also in macrophage system, where they recycle red cells. So hepcidin is the main iron regulator, which is synthesized in the liver, and it is, the most important thing is, it is an acute phase reactant which has some intrinsic antimicrobial activity, and it inhibits iron absorption in the gut and release of iron from the macrophage system and from the liver as well. So these are the actions of hepcidin. It inhibits iron absorption from the gut, that is the duodenum, and the release of iron from macrophages as well as from the liver. So what are the negative regulators of hepcidin? So negative regulators, they reduce the level of hepcidin, which leads to increased absorption of iron. So mainly it is due to blood loss, hemolytic anemia, ineffective erythropoiesis, and recovery from anemia, as well as hypoxia and testosterone. So these are the factors which reduce hepcidin level in our body, increasing the absorption of iron. And positive regulators are iron status. If you are saturated with iron, hepcidin level will be low. And other thing is chronic inflammatory conditions, or even in acute conditions. So how does iron distributed in our body? The total iron level in our body is roughly around 4 grams in our body. So it is mainly stored in hemoglobin, as hemoglobin, and in iron stores as transferrin, ferritin, and hemosiderin. What is the daily dietary requirement? So that depends on the gender as well as the pregnant status. So for a elderly lady, that is postmenopausal lady, or men, it would be around 8 milligrams, and in a menstruating female patient, it will be about 18 milligrams per day, and during pregnancy it goes up to 27 milligrams, and lactation a little bit higher than a normal lady, that is 9 milligrams. So out of your dietary iron intake, 10 to 15 will be absorbed in the duodenum. And the interesting thing is, once you absorb iron, there is no mechanism to excrete excess iron. So males, you can excrete about 1 milligram per day, and in females about 2 milligrams per day. That is mainly from shedding of skin mucosal membranes and gut mucosal membranes. So these are the common foods which contain high amount of iron. Out of that, lentil curry has the highest amount of iron, and again Gotukola sambal has significant amount of iron, and interestingly pumpkin also has significant amount of iron. And when you talk about our rice varieties, we have a lot of rice varieties in our country, maybe thousands Asian rice varieties. They contain significant amount of iron. So they can provide up to 6 milligram of daily iron requirement. And but unfortunately, polishing of rice reduces their iron content almost by 90%. So what are the causes of anemia in adults? So anemia we broadly categorize as microcytic anemia, normocytic anemia, and macrocytic anemia. Here I am only going to talk about microcytic anemia. So again, it can be divided as microcytic anemia with low or normal retic count, and microcytic anemia with high or high retic count. So microcytic anemia with low or normal retic count is mainly secondary to iron deficiency and anemia of chronic disease, cerebroplastic anemia, copper deficiency, or zinc poisoning. And in thalassemia and hemolysis, if there is no iron deficiency, usually you are having high retic count. So what are the causes for iron deficiency anemia? It can be secondary to reduced iron intake, and again it can be secondary to increased iron demand as well as decreased absorption and chronic blood loss. So demand goes up during the pregnancy and during your growth spurts and menstrual loss, and people who are donating blood frequently and who are involved in sports. And iron absorption is reduced in any disease which affect your duodenum, and in conditions where your acid level is low in the stomach. So it can be secondary to celiac disease, atrophic gastritis, and gastrointestinal bypass, and inflammatory bowel diseases, H. pylori colonization, and concomitant use of proton pump inhibitors. And the most important thing is chronic blood loss, which can be secondary to a condition like gastrointestinal malignancy. And the other thing is it can be blood loss in any other place, maybe genitourinary, maybe systemic conditions like hemorrhagic telangiectasia and eating disorders, and chronic schistosomiasis. So this is a study which was performed in UK to assess the prevalence and etiology for iron deficiency. So in their country, it is mainly due to non-GI blood losses. That is about 20 to 30%. That is secondary to menorrhagia, and from GI blood losses, that is mainly due to NSAIDs and aspirin use. And there is significant amount of patients who are having colonic carcinomas as well. So what are the features of iron deficiency? I would like to talk about these features later when I'm going to talk about the iron deficiency without anemia. But basically, it can be symptomatic anemia, which is with weakness, exercise intolerance, and dyspnea, sometimes headache, and they can present with pica. Pica means compulsion to eat substances not fit as food particles, and mainly they are having ice craving, which is significantly specific for iron deficiency. And also they can present with restless leg syndrome, and sometimes with beeturia. Beeturia means if they eat beetroot, they pass red colored urine, and it is also significantly specific for iron deficiency. So what are the signs? So they are pale and they are having dry or rough skin, and they can get atrophic glossitis and atrophy of tongue papillae, and they can get angular stomatitis and koilanoikia, and sometimes they can present with dysphagia and iron deficiency and esophageal webs, which is known as Plummer-Wilson-Patterson-Kelly syndrome, and they can present with alopecia. And those days, especially in young adolescent white girls, they presented with chlorosis, that is faintly green complexion with pallor in their skin. But these days we don't see these features. So this picture shows angular stomatitis and glossitis and koilanoikia. And how to investigate iron deficiency? So I'm going to focus about the iron deficiency mainly. I'm not going to talk about investigations in anemia. So first you have to do full blood count with red cell indices, and you have to do a blood picture and the serum markers of iron deficiency. They are serum ferritin, serum iron, total iron binding capacity, iron saturation, and serum transferrin receptor level. And finally, you can do bone marrow aspiration samples and iron staining as well, which we usually don't perform to diagnose iron deficiency per se. So what do you see in red cell indices? Usually they get microcytic and hypochromic cells, and MCH is the most reliable investigation because it is less affected by counting machine and storing of blood. And RBC count is low because there are no raw materials to produce red cells, therefore red cell count is low. And if RBC count is increased, that is indicative of thalassemia trait. And the other thing is red cell distribution width. It is increased if there are various sizes of red cells. So if patient is having coexisting B12 or folate deficiency, there will be another clone of macrocytic cells, which increases red cell distribution width. So this is a blood picture which shows small lymphocyte. Usually red cells are in the size of a small lymphocyte nucleus. So here all these red cells are small to the size of the lymphocyte nucleus, and you can see very pale center which are microcytic cells, and there are pencil cells as well. So this is hyperchromic microcytic blood picture with pencil cells suggestive of iron deficiency. And this is another blood picture which shows hyperchromic microcytic cells, but inside this red cell you can see some iron deposits, droplets. So they are termed as Pappenheimer bodies, which is secondary to sideroblastic anemia, which is again another cause for microcytic anemia. So what are the serum markers of iron deficiency? So ferritin definitely should be low, and iron should be low. Total iron binding capacity is increased, and iron saturation or transferrin saturation should be low, and cutoff level is 20%. And red cell zinc protoporphyrin is increased, which we don't. That in this case we don't do here. And you can do serum transferrin receptor level, and because it's important because it is not affected by acute inflammation. So in inflammatory diseases with anemia you can do that. And the disadvantage is if you ingest a small amount of iron, it can reduce the level of serum transferrin receptor level. So few facts about serum ferritin. It is the most powerful test in diagnosing iron deficiency anemia in the absence of inflammation. And the thing is, it does not parallel the changes of inflammatory markers. So ESR can be normal, it can be high, but you cannot correlate the level of ferritin to ESR or CRP. And sometimes it can be high even with normal ESR or CRP. And if it is less than 15 nanograms per milliliter, it is 99% specific for making the diagnosis of iron deficiency. And the cutoff level for iron deficiency should be less than 30 nanograms per milliliter. But in conditions like Restless-Legs syndrome, we consider even less than 75 as iron deficient. So there are several other conditions which can increase the serum ferritin level. So one is alcohol consumption and obesity, and non-alcoholic fatty liver disease or fatty degeneration of the liver. And the individual level can vary according to their genetic predisposition. So even though we consider 30 as the cutoff, still for another patient it can be higher value. and it should not measure during acute febrile illness or during any other acute inflammatory condition. So this is the algorithm which shows investigation pathway for iron deficiency. If you suspect iron deficiency, you have to take a proper history to identify what is the reason for this iron deficiency. Then you have to obtain iron studies, and you have to do serum ferritin. And if iron deficiency is confirmed, you have to identify source of iron deficiency and treat with iron and treat the underlying condition. And serum ferritin is less than, if it is more than 30, you have to do transferrin saturation if you still suspect iron deficiency, and if it is less than 20, you have to follow the same algorithm. So iron deficiency in chronic inflammatory diseases. So what are the main chronic inflammatory conditions? We have to consider in CKD, because iron deficiency and anemia is very common in CKD, heart failure and inflammatory bowel diseases. So their cutoff level is higher. We take it as 100, and we have to do transferrin saturation if serum ferritin is in between 100 to 300, and if transferrin saturation is less than 20, we take it as iron deficiency rather than anything else. So how do you establish the cause of iron deficiency? So you have to take a proper dietary history, because sometimes in people who are taking a vegetarian diet may not take adequate iron in their foods. Another thing is family history. You have to take a proper history about possibility of history of colorectal malignancy. So what is the significant family history of colorectal malignancy? If there is one affected first degree relative less than 50 years of age, or two first degree relatives irrespective of the age. So these are things you have to assess in examination of the patient. So what is the first picture? You can see some telangiectatic patches. So it is due to hereditary hemorrhagic telangiectasia, and the other picture shows some hyperpigmented patches around the lips, which can be secondary to Peutz-Jeghers syndrome associated with adenomas, colonic adenomas. And as always, you have to stick into your basic investigations. You have to do UFR and see whether the patient is having red cells in urine, and 1% of iron deficiency anemia is associated with renal tract malignancies, maybe a renal cell carcinoma or carcinoma of the bladder, and 1/3 of renal cell carcinoma patients are anemic. And all the patients should be screened for celiac disease according to British guidelines, but we don't know about the prevalence of celiac disease in our country. According to one study in Asian countries, the prevalence is about 0.6%, whereas in European countries it is about 1.4%. And when do you decide about upper GI and lower GI endoscopies? So all male patients and postmenopausal females with confirmed upper iron deficiency with no significant non-GI blood loss, you have to perform a endoscopy, upper GI and lower GI. If OGD is performed initially, only percent of advanced gastric cancer or celiac disease should defer the lower GI endoscopy. If celiac disease is diagnosed, still lower GI endoscopy should be performed if age is more than 50 years, and if there is significant family history of colorectal malignancy, and if patient is having severe anemia. So what about small bowel investigations? Usually direct visualization of small bowel should not be performed unless symptoms of small bowel disease is there, and if hemoglobin cannot be restored or maintained with iron therapy. Otherwise, we only perform upper GI endoscopy and colonoscopy. What about premenopausal women with iron deficiency? All these patients should be screened for celiac disease, and upper GI endoscopies and lower GI endoscopy should be reserved for patients whose age is more than 50 years and who are having symptoms suggestive of gastrointestinal disease, and if there is strong family history of colorectal malignancy. So what about iron deficiency with normal hemoglobin level? Usually, if hemoglobin level is normal, even though patient is having iron deficiency, endoscopy is rarely detects a malignancy. If there's a malignancy, patient is usually anemic. And endoscopy should be performed after discussed with the patient about risk and benefits in postmenopausal females and males more than 50 years only. Usually we perform fecal occult blood. The reason is to decide whether this patient needs endoscopies or not. But fecal occult blood is not recommended in recent guidelines because it has very low sensitivity and specificity, and it depends according to the method you analyze the sample. How do you manage iron deficiency? So there are two ways of managing. You can go for oral iron preparations and parenteral iron preparations. Replacement dose should be 100 to 200 milligrams of elemental iron. So 100 to 200 elemental iron. So these are the preparations which are available: ferrous fumarate, ferrous gluconate, and ferrous sulfate, and dried ferrous sulfate. So this is the one which we usually use in our country, that is dried ferrous sulfate, which contains 65 milligrams of elemental iron. So generally should not be given with foods because it will affect the absorption, and should separately taken with calcium containing foods or beverages like milk and calcium supplements, cereals, dietary fiber, tea, caffeine, and eggs. And it should not be taken with drugs reducing gastric acidity like antacids and drugs like simritidine and PPN. And absorption of non-heme iron, uh, the positive factors which affect the absorption are ascorbic acid and meat or fish. Factors in meat other than heme iron enhance absorption of non-heme iron. That's the reason for that. And negative factors are phytate in bran, oats, and fiber, and polyphenols, which are in tea and some vegetables and cereals, and dietary calcium and soy proteins. And if a patient is taking antacids, it should be given 2 hours before or 4 hours after antacids, and usually with vitamin C or glass of orange juice. And the other thing is, if you are using long-acting sustained release iron formulation, should be usually avoided because by the time of its release, it might pass the main site of absorption, that is duodenum. Therefore, they are not recommended in iron replacement therapy. So, what are side effects of oral iron preparations? Actually, they are having less side effects. Mainly, they develop constipation and fecal infection. Therefore, we have to take some precautions when you are prescribing these drugs for patients with intestinal strictures and diverticular disease. And also, it can exacerbate diarrhea in inflammatory bowel disease patients. So, parenteral iron preparations. So, what are the indications for IV iron? If your patient is unable to tolerate iron due to gastric side effects, gastrointestinal side effects, and if patient is having poor compliance, and if patient is having continuing blood loss that exceeds the capacity of oral iron to meet the demand, and if patient is having malabsorption, and if patient is having coexisting inflammatory conditions that interferes iron homeostasis, and if you want to replete iron stores very quickly, you have to use intravenous iron preparations. But it has a lot of side effects, not like oral drugs. Patient can end up with anaphylactic reactions. And how long we are going to give iron? So oral iron, usually we have to give for at least 6 months to replete iron stores. Some physicians, they stop iron treatment once hemoglobin level is normalized, because then you can monitor the patient for ongoing blood losses. The problem is prolonged unmonitored iron therapy can give rise to iron overload, especially in patients who are undergoing multiple blood transfusions. So these are the iron preparations which are available: ferric carboxymaltose, iron dextran, iron isomaltoside, and iron sucrose, which is the commonest one we use in our country, which contain 20 milligrams of elemental iron in 1 milliliter. It comes in 5 milliliter ampoules. So, how do you calculate the intravenous iron sucrose dose. So it depends on the total iron deficit, which depends on the weight of the patient and target hemoglobin level and iron stores. So this is the formula, which is a little bit complex one, but you can use this. You can get it from internet, and you can calculate total iron deficit. So total iron deficit should be divided by 20 milligrams, because it is the amount of elemental iron in 1 milliliter of ferrous sucrose. This is another chart which shows the requirement of replacement dose according to the weight of the patient and the present hemoglobin level. So as I told you previously, intravenous iron can give rise to serious problems. Patient can end up with anaphylactic shock. Sometimes they can develop febrile reactions, and the other thing is, we had a patient with some altered level of conscious level and encephalopathy like picture, and patient ultimately underwent a lumbar puncture as well, and all the investigations normal. Therefore we thought it's secondary to intravenous iron benefit. So if your patient is not responding to iron treatment, what could be the reasons for that? So patient may be having some existing disease which interfere with the bone marrow response. So it can be an infection, an inflammatory disorder, and underlying malignancy, and patient may be having coexisting folate and B12 deficiency, and there may be some bone marrow suppression as well. And the other thing is, that may not be the correct diagnosis. The patient may be having underlying thalassemia trait, or something like lead poisoning, or anemia of chronic disease, copper deficiency, or zinc toxicity, or myelodysplastic syndrome, or sideroblastic anemia, as we discussed previously. And other thing is poor drug compliance, and other thing is poor absorption. Patient may be having some problem affecting the absorption of iron in duodenum, and the other thing is patient may be having continued blood loss. So this is a very interesting entity actually, iron deficiency without anemia. It has been known for a long time, but we haven't focused on that until recent years. So iron is a very important cofactor for a lot of enzymes in our body, including cytochrome C, cytochrome oxidase, and thyroid peroxidase, and various other enzymes. And these enzymes are necessary for the normal function of our body. So it needs for energy metabolism and brain functions, and thyroid hormone synthesis. So if your patient is iron deficient, then can lead to various symptoms which cannot be explained by usual symptoms of iron deficiency. So they can present with exceptional fatigue, and reduced mental awareness, and absent-mindedness, and poor concentration, headaches, hair loss, and globus, pharyngeal irritation, and phlegm, dysphagia, cough. So it can mimic anything actually. So we have to address iron deficiency in a patient with multiple complaints, and there are other various diseases also which can give these symptoms, such as hypothyroidism, vitamin D deficiency, B12 deficiency, celiac disease, testosterone deficiency. So there are a lot of other conditions which can give rise to same symptoms. So most of the time these iron deficient patients are diagnosed with something else actually. They were treated for something else without any improvement. So they may be diagnosed as hypothyroidism, melancholy to severe therapy resistant depression, migraine, asthma, fibromyalgia, and poor improvement of fitness on exercise, unremittent weight gain. So for an example, if your patient is having iron deficiency, they can develop thyroid hormone dysfunction, that is mainly due to thyroid peroxidase malfunction. So TSH level be little bit high, you are going to replace the patient with thyroxine hormones, but patient is still symptomatic unless you recognize underlying iron deficiency. So this entity we have to pay much more attention actually, because it can mimic various other conditions. So finally I would like to discuss one case true patient who came to our hospital. This is a 58-year-old man referred to the medical clinic due to anemia. He was on iron supplements for 10 years, and this is his full blood count. I think it's clear, even though it's a little bit darker. So hemoglobin is 10.5, And if you look at the red cell indices, MCV is 62.7 and RBC count is 5.2. So RBC count is upper limit of the normal range. So what do you think? Other cell lines are not affected, and ferritin level was 1500, iron saturation was 55%. So cutoff for iron overload is 40%. So patient is definitely iron overloaded because of iron treatment. So what is the underlying pathology? There's a thing called Mensa index, or we call it commonly as thalassemia index, that is MCV divided by RBC. If it is less than 13, it is more suggestive of thalassemia trait. So what is the thalassemia index in our patient? It is 12.05. So patient is having undiagnosed thalassemia trait, and patient is iron overloaded because we have prescribed iron for 10 years period without any proper response. So if patient is iron overloaded, what will happen? Patient will get target organ damage. So what are the target organs? It can affect hypothalamo-pituitary axis, mainly leading to hypogonadism, premature menopause, like that, and later other hormone systems are also will get affected. And in the heart, you can get dilated cardiomyopathy, you can get bronze diabetes, and in the liver, you can get fibrosis and cirrhosis and skin hyperpigmentation. And the interesting thing is, if your patient is iron overloaded, they are prone to get infections. So the main reason for that is neutrophil dysfunction. So in countries where TB and malaria is common, if you overload these patients with iron, they are prone to get infections with reinfections of infections with TB and malaria. Therefore, WHO also does not recommend empirical iron treatment in countries where TB and malaria is endemic. So the take-home message is unmonitored iron therapy is a crime. Actually, you have to monitor if you are treating a patient with iron.
Thank you very much, everybody. We will conclude the meeting today.
And
thank you very much, Dr. Rathnayake. That a comprehensive talk on a very important topic. If there are any questions, we can have a couple of questions.
usually we are giving ferrous sulfate with vitamin C because it increases the absorption of elemental iron. We don't get combined tablets in the government sector, but there are other formulations with combined vitamin C.
Thank you very much. And on behalf of the Srilankan College of Physicians, I thank you very much for delivering this talk and make sure our appreciation valuable in this certificate.